Hello everyone. Let's talk about INR today. You may be receiving multiple calls about high INR or INR reversal in your day-to-day hematology reg on call. So INR is of two types which are high. Either the patient is taking vitamin K antagonist or the patient INR is high because of some other reasons. So when the ED doctor or medical doctors or other team call you that the patient INR is high, what should we do with that? Ask them if the patient is on vitamin K antagonist or not, or this is non-warfarin related high INR, because the treatment is a bit different in both the cases. So if the patient is taking warfarin and INR is high, there is a separate protocol for that, which sometimes include prothrombin complex concentrate, which comes under different name, octaplex and beriplex. Some NHS trust use octaplex, some use beriplex, depending upon the trust policy. And different overseas hospitals may be using different product as well. So ask the team when is the procedure. For example, they say that this patient need urgent procedure, emergency procedure, and we want to reverse the warfarin in this patient. Ask them what is the INR and when is the surgery. Emergency surgeries are usually on the same day or within few hours, okay, because of the urgency of the situation. So if you open the SPC of prothrombin complex concentrate octaplex, it clearly tell you that if the INR is between 2 to 4, then you should give them 25 international units of octaplex per kg. Maximum dose should not go above 2500. If the INR is between 4 to 6, then the maximum dose of the octaplex should be 3500. And how you will give octaplex to this patient? The 35 international units per kg. If the INR is above 6, then it is 50 international units of octaplex per kg, and maximum dose should not be above 5000 units. Um, it may vary from trust to trust, but this is the updates in the Octaplex SPC. If your hospital is following is using Octaplex in your hospital, then follow this guideline for INR reversal in a patient who is taking warfarin. Okay. Similarly, if the patient is bleeding on warfarin and the ED doctor call you that we want to reverse his INR, ask him what is the INR in this patient. If it is 2 to 4, 25 international unit per kg octaplex. If it is 4 to 6, then 35 international unit per kg of octaplex. If it is more than 6, then it is 50 international unit per kg of octaplex. So it depends on the INR, and the INR help you in calculating the optimum dose of the PCC or octaplex for the patient. Always give them vitamin K along with the octaplex. It help in reversing the INR as well. Usually, it takes 4 to 6 hours to achieve the hemostasis, and most of the patients do not require a second dose of PCC while managing bleeding or reversing the high iron. Secondly, if this patient is on warfarin, but INR is high, not no bleeding, and patient is not going for any surgery, then different hospitals have different protocol for them. If the INR is above 8, usually we stop the 2 to 3 doses of warfarin and give them 5 milligram of vitamin K as well. Some hospitals says 2 milligram of vitamin K. It depends on your trust policy, but we do not give them PCC. Okay, so If there is no bleeding, patient is not going for any emergency surgery, and INR is about 8, stop warfarin for 2 to 3 doses, and no PCC is required in this case, only vitamin K. If the INR is between 5 to 8, again, we stop few doses of warfarin in the patient. Some hospital give 2 milligram of vitamin K. My trust do not give 2 milligram of vitamin K. We only skip 2 to 3 doses of warfarin. And we restart the warfarin again when the INR is in therapeutic range. But this time, when we restart the warfarin, the dose is 10 to 20% less. If someone is using 8 milligram of warfarin daily, we make it 7 milligram or 6 milligram. Okay, and then monitor the INR again. So if the patient is on warfarin, it depends whether he is bleeding, she is bleeding, or the patient is going for emergency surgery or not. If the patient INR is only high, but there is no bleeding and patient is not going for emergency surgery, it matters. Do not give PCC for every high INR. PCC is a very prothrombotic product. You may lead to arterial or venous thrombosis in the patient, leading to strokes and MIs as well, or limb ischemia, bowel ischemia, etc. Be careful about this product as well. Now, you may receive call from your ED doctors that this patient is not on any anticoagulation, but the patient INR is high. What to do with this high INR? Then look for the causes. Maybe this patient has liver dysfunction. If there is any liver dysfunction, INR would be high. Because with liver dysfunction, you will have noticed that your prothrombin time is high, and the INR depends on prothrombin time, and INR will be high as well. Once the liver function come back to normal, then the INR come back to normal as well. In such cases, we usually give them vitamin K, 2 milligram for 3 days, once daily, uh, and then liver. Once the liver function is normal, INR become normal as well. Sometimes patient liver is normal, INR is high. Maybe this patient is vitamin K deficient. Some of the trust in UK can check vitamin K level in this patient, and um, some do not have this facility, but mostly in children, you will see that their INR is high, PT is deranged, sometimes APTT is deranged as well, slightly high. But they are not bleeding, they are not on any anticoagulation. What can be the reason for this? Likely vitamin K deficiency. Give them few doses of vitamin K, then recheck the INR, it will be okay. So there are many differentials of high INR. It can be vitamin K antagonist, vitamin K deficiency, malabsorption, liver diseases as well. What about FFP? FFP leads to suboptimal correction of uh, INR, and the drawback or side effect is that you are increasing the volume, plasma volume of the patient. So those patients who are at risk of overload, like liver cirrhosis patient, their INR is always deranged because of liver cirrhosis. Their liver functions are deranged, and PT INR are deranged in most of the cases as well. Do not give them FFP. By giving them FFP, you are increasing the portal pressure. Portal pressure can lead to exacerbation of the esophageal and gastric varices and risk of bleeding. So actually, you are increasing the risk of bleeding in these patients by giving them FFP. And also the BSG, British Gastroenterology Society guideline says that FFP is only for bleeding patient or DIC patient with bleeding. If the patient is not bleeding and patient is not in DIC and not bleeding, FFP are not indicated. Okay, so uh, British Society of the Gastroenterology, they have their own guidelines as well regarding the FFP. And also BSH says as well. If patient is not bleeding, no indications of FFP. You do not give FFP for correcting INR or PTA/PTT. It is only for uh, bleeding patient with deranged coagulation screen because of a risk of increasing um, plasma volume and bleeding. So next time, whenever you receive a call from your ED colleague and other specialties, and they says that INR is high, what to do? Ask them if the patient is using warfarin or not. If the patient is not using warfarin, then it may be vitamin K deficiency or it may be related to liver dysfunction. Address the causes. If the patient is on warfarin, and then if it is above it, skip few doses of warfarin and then restart the warfarin with a small doses. If the patient INR is between, let's say, 5 to 8, again, skip few doses of warfarin, read your trust policy whether they want to give vitamin K or not. Maybe they say 2 milligram of vitamin K. Some trust may say no, just whole few doses of warfarin. If the INR is about 2 to 4, skipping one dose is okay and restart the warfarin with a bit of a small dose. Reduce 1 milligram or 2 milligram. As I have given the example that if your patient is using 8 milligram, restart with 6 milligram and monitor the INR in these patients. So I think if you have INR question in the future as a hematology reg on call, it should be easy for you now to address it and read your trust guideline or hospital guidelines, whether they use octaplex or beriplex, because we have used octaplex since long, and I'm aware of octaplex guidelines, the maximum dose and the dose of octaplex um, according to the INR. Your hospital may be using beriplex. Uh, and its doses may be slightly different, especially the maximum dose. So it is necessary to know your trust policy or hospital policy as well, so that you can quote in the exam. According to my trust guideline, the maximum dose of octaplex in a patient who is bleeding and INR is more than 6 is 4,500 or 5,000 units. So in this way, you can defend yourself in the FRC path exam, and they consider that. Do not worry if there is a slight difference from the national guidelines. So thank you very much.